you very much, and welcome to this policy webinar on specialist payment models, design, and impact. First, I'd like to provide a land acknowledgement. I'm John Sproul. I'm Senior Policy Director with the Institute of Health Economics. And the Institute of Economics acknowledges that we're located on Treaty 6 territory, the traditional and ancestral territory of the Cree, Dene, Saulteaux, Nakota Sioux, and the Blackfoot, and also it's the home for Métis settlements in the Métis Nation of Alberta. And we make this acknowledgement as an act of reconciliation and gratitude to those whose territory we reside on or are visiting, and whose histories, languages, and cultures continue to influence and enrich our community. We acknowledge the harms and mistakes of the past and the enduring effects of systemic racism, and we dedicate ourselves to creating safe and inclusive spaces that strengthen collaboration, build respectful relationships, and engender change. And we hope that this space that we're all in together now is one that is going to be respectful, strengthen collaboration, and engender some change. Just the agenda, we're going to be having a couple of presentations. One is a recent work that's been conducted in Alberta looking at specialist payment models and clinical and economic outcomes. And Sandeep Chand, who's a master's student with community health science, is going to be presenting that recent study that's been completed. And then an overview of specialist payment models, key findings and implications from Dr. Amity Quinn, who's really looked at this area extensively and will provide some food for thought. And then we'll have a discussion with Dr. Glenn Sumner, who is a cardiologist, as well as actually having some advanced economics training. And I think is chairing the working group with activity-based funding work in the province of Alberta. And then Dr. Jason Sutherland, a colleague who is the executive director, head of CHESPR with the Center for Health Services Policy Research at the University of British Columbia. So hopefully it will be insightful. The partners, certainly we're supported by the Alberta government in conducting a lot of activity, work with the Obrien Institute of Public Health, and I would note that a couple of our key presenters are from the University of Calgary, the UBC Centre for Health Services and Policy Research, and also the Network of Alberta Health Economists, which we serve as a secretariat for, and both U of A and UofC are involved in that. And this is part of an ongoing series of policy webinars that we conduct, and we plan to do a bunch around provider payment throughout the fall and into the spring. Anybody who has suggestions of topics, please get back to us on that. The QR code is there, and I'll show it again at the end. That is to the event website, and I'll send it around afterwards, but we'll have the PowerPoints posted today that are used, and then we should have a recording of the webinar, which you can share with people next week. So there is the QR code if people want to kind of grab it right away. And again, you can certainly send any emails to me about that. But I will now, I've stopped sharing, and I'll pass over to Sandeep, who's going to be providing a presentation on the recent study that's happened in Alberta, but hopefully going to be able to learn things and think of questions that you have, and hopefully this will be a useful learning experience for you. But over to Sandeep.
Don't forget to unmute, Sandeep.
Yeah, thank you so much, John, Mark, and thanks to the IHE team for having me. So everyone, I'm Sandeep Chand. Today, I want to answer one question. Does the way we pay heart specialists change the care that heart failure patients actually receive? We followed a select population of adults in Alberta newly identified with heart failure and referred to a specialist for 5 years. And here is what we found. First, why heart failure? It is a condition where the heart cannot pump well enough to keep with the body needs. More than 100,000 Canadians are diagnosed every year. In Alberta, it affects about 2% of adults and leads to roughly 6,000 hospital admissions a year. Heart disease overall costs Canada about $7.8 billion annually, and about 12% of that goes to physician payments. Now look at how we pay those physicians. About 83% of Alberta doctors are paid entirely fee for service. They bill for each service provided. Nationally, about 72% of physicians flow that way. The main alternative is salary, a set amount regardless of volume. This matters because physicians' decision may influence up to three-quarters of what our health system spends. So here's the tension and the picture on the left as a whole argument. A recent Alberta study found fee-for-service cardiologists submit about twice as many outpatient imaging claims as salaried ones. Unnecessary repeat testing costs money and it adds to everyone's as wait time. But less testing is not automatically better. Undertesting can mean a delayed or misdiagnosis. In a public funding system, the goal is not fewer tests, but the right test for the right patients. We know payment models were linked to how much testing happens, and we didn't know whether the extra testing changed cost or whether patients ended up any better or worse in terms of important clinical outcomes. So we had four aims. First, a systematic review, gathering everything already published on specialists in cardiology are paid and what this linked to. Then we asked three questions using Alberta's own health records, comparing patients whose main specialist was fee for service against those whose specialist was salaried over 5 years. First, how much care did they use? What happened to them clinically? What did it cost? And how did it differ by payment model? Utilization in our study means cardiac tests and follow-ups. Clinical outcomes measured include heart failure hospitalization, emergency visits, and that from any cause. Let's start with the systematic review, which has been published. We searched six databases through August 2025 for studies comparing how cardiologists are paid. 4,156 records came back. After screening, six studies remained. On testing, the signal was reasonably consistent. First, patient of the fee-for-service cardiologist, especially the highest billers, receive more cardiac tests and more procedures than patient of the salaried or capitation-paid cardiologist. Other than the past testing, the evidence was scant. There was almost nothing on whether the patients differed in terms of overall comorbidities, nor was much on cost. We aim to fill that evidence gap with our retrospective Alberta-based study. Uh, we took every adult newly identified with heart failure between 2014 and 2018 who was referred to a specialist and followed each of them for 5 years. The clock starts at their first outpatient consultation. This comes from province-wide administrative records, hospital records, billing claims, prescriptions, and vital statistics linked by a unique patient's number. On the specialist side, we included cardiologists and general internists who stayed in the same payment model for at least 6 years, excluding switchers who switched from one payment to another, locum physicians, physicians near retirement, and very low volume physicians. That left 237 specialists and 7,385 patients. Here is an important point. The two patient groups were not alike to begin with. Different cities, different rural urban mix, different illness, etc. So we use propensity score matching. We paired each patient's salaried patients with fee-for-service patient who looked as similar as possible on age, sex, location, socio-economic factor, medication, and other condition. That gave us 627 well-matched pairs. Now here are the results. This follows plots shows that five outcomes over 5 years. Each dot is a comparison between the two groups. The line through it, the confidence interval, the vertical line down, the middle indicates the line of no difference. If a horizontal line crosses it, we cannot say the group differ in that characteristics. One outcome stood out, the amount of cardiac testing ordered or patients received. Patient whose specialist was paid fee for service received cardiac test at around 3 times the rate of patients whose specialist was salaried. The testing included mostly echoes, nuclear imaging, and stress tests, and some angiography. Importantly, increased testing in the patient cared for by the fee-for-service doctor. There was no significant difference in important clinical outcomes, including heart failure hospitalization, emergency department visits, and all-cause mortality. To summarize, in the fee-for-service patient group, there was 3 times the cardiac testing and no measurable difference in clinical outcomes. This slide shows the difference in cost. Keep in mind that this is a logarithmic scale. Three differences were statistically significant. First, the cardiac testing cost, $51 per patient over 5 years in the fee-for-service group versus $16 in the salaried group. A small number is in absolute terms, but a threshold cap and the amount consistent finding in the whole study. Hospitalization cost about $6,400 per patient versus 3,250. This is the difference that actually moves the total, and the overall cost over here roughly $6,900 dollars versus 3,700, close to double. Follow-up visits and emergency visits showed no difference. So the overall gap is driven by testing and mostly by the hospitalization cost. So why more testing? First, how solid is this finding? This table runs the same comparison of different ways, our match group, cardiologist cohort, a broader cohort, and a version measuring for fee-for-service patient to each salaried patients. Read across the top rows. Each column shows significant more cardiac testings in the fee-for-service group between roughly 1 and 3/4 time and 3.5 times. The direction never flips. Now, if we read the rows below, the follow-up, hospitalizations, emergency visits, mortality, none of is significant in any column. One important cautions, we did not assess whether any individual test was clinically appropriate, so we cannot call it this overuse. What we can say is that the link between how specialist is paid and how much testing their patient get is strong and consistent in our all different kind of analysis that we performed. The cost picture is less uniform. Testing costs were significantly higher in the fee-for-service group in all four analyses. That one holds everywhere, and it follows directly from the testing results. Hospitalization overall costs were significantly higher in our main analysis, which is the primary analysis, and in the 4-to-1 analysis, which is 1-to-4 matching, but none in the cardiologist only subgroup and none in the broader cohort group that we observe the difference in hospitalization costs. One possible explanation for the hospitalization gap is that fee-for-service patient had more resource-intensive admission. That what we observe in our raw data. The summary is the testing cost finding is robust. The larger dollar figures are suggestive, but they depend on how you define the group. Quickly about strength and limitations. Strengths were, in our study were carefully defined a new cohort, matching 5 years of follow-up as far as we know. The first study to examine both cost and clinical outcome in cardiology care by payment model. There are some limitations in our study as well. They are billing records, not charts, so we cannot see clinical reasoning. 627 payers in modest sample. A real difference in death or hospitalization could exist and still too small for us to detect. Unmeasured difference may remain, and while we could identify each patient's main specialist, we cannot always confirm that the same specialist ordered each test. The conclusion is patients seen by fee-for-service specialists consistently receive substantially more cardiac testing and cost the system more, with no difference we could detect in hospitalization, emergency visits, and survival. However, our findings should not be interpreted as showing that fee-for-service causes high utilization or poorer care, nor we can determine whether individual tests were clinically appropriate. Rather, they highlight an important association between physician remuneration and pattern of healthcare delivery. We conducted this research primarily through the lens of publicly funded healthcare system. However, more research is needed across broad range of specialists and from multiple perspectives, including physicians, payer, and patients, to better understand the impact of different payment models. Uh, now, I would like to acknowledge all the team members involved in the study. So I would like to thank my supervisor, Dr. Glenn Sumner, and my internal committee member, Dr. Satish Raj, Dr. Derek Chu, and Dr. Kathy Eastwood, to our external advisors, Dr. Amity Quinn, Dr. Tara Witten, Dr. Paul Ronsley, Dr. Stephen Addington, volunteers for helping us in systematic review, Riley Martin and Melissa Monaghan. I also would like acknowledge the organization that help us in every step of the hurdle, Department of Community Health Sciences, Lebanon Cardiovascular Institute, Alberta Health Services, and Center for Health Informatics. Now I would like to pass it to Dr. Quinn.
Okay, thanks. If you could stop sharing, Sandeep, that's great. Just as thanks very much. And so we just wanted to highlight the very specific study, but as we're switching over, just a quick question, Sandeep. I was wondering if, because it had come up in some other work, and I'm the moderator, so I have the bias or the privilege of being last. Was age looked at all in terms of the providers? Because it sometimes, in terms of particular ordering of tests and use, sometimes is determined by what period of time they went to medical school and were trained in moving forward. And I'm just wondering whether age or gender was examined at all in the analysis of, just if you might answer that question before we move to Amity.
Thank you, John. I think this is an important question. So in our study, we only balanced the patient characteristics. We although consider the characteristics of physicians in our study, but we did not balance the physician characteristics, although we have all the important baseline characteristics like the age, the sex, the location, where did they pursue their specialty. Although this is the table that we have is ready for the publication. Sorry for not including in the slides.
Oh, no.
But we did, but we did consider, but not for the matching.
Okay, great. Thanks very much. Amity, over to you. Thanks very much.
Thanks, John, and thanks, Sandeep, for setting this up. Okay, so you can just see my actual slides, right? Not my notes. We're good.
Yes, we can just see your slides.
Okay, excellent. All right. Okay, so my goal today isn't to review every specialist payment model, but I want to take a step back and ask what the broader evidence shows and what that means for future policy reforms. In my 2020 systematic review on the impact of specialist payment models, the strongest and most consistent effects of specialist payment reform were on utilization, while evidence on quality, patient outcomes, and costs was much less consistent. Since then, the evidence base has grown, but we still haven't identified a universally superior payment model. So I'm not really interested in the question, which payment model is right for specialists in Alberta. The question I find more interesting is, what can payment reform realistically accomplish? So specialists play a central role in how health systems function. They influence referrals, diagnostic testing, procedures, treatment pathways, and ultimately a substantial share of healthcare spending and resource use. At the same time, physicians occupy a unique position within Canadian healthcare. Unlike most healthcare workers, specialists have substantial professional autonomy and operate outside traditional management structures. So this has important implications. If governments want to improve access, reduce wait times, address unwanted variation, or encourage new models of care, they often have relatively few direct levers available. So payment policy becomes one of the primary ways the health systems can actually influence physician behavior and try to align care with broader system goals. So that's a reason specialist payment remains such an important policy topic, and I get to keep studying it over and over and over again. But it also means that payment reform is often being asked to accomplish a lot. So a question that I've been thinking about and for this presentation is how much can we realistically expect payment reform on its own to achieve? So before looking at the evidence, I just want to make sure we're all on the same page about what different models are and what they encourage. So fee-for-service tends to reward activity, while salary-based payments place less of an emphasis on volume. And other models attempt to reward continuity, coordination, efficiency, or measured quality. And again, none of these is inherently good or bad, but they simply create different incentives and different trade-offs. In Alberta, most specialists, as Sandeep already talked about, are fee-for-service. Some are paid salary-like models, but they remain independent contractors rather than an employee of a healthcare organization. So an important question for policymakers is whether those incentives align with the goals they're trying to achieve. So with that in mind, let's look at some more evidence. This is a QR code to my systematic review, which John said they were already shared in online. But so first, payment models, like Sandeep has already sort of reviewed, do affect physician behavior, but particularly they're affecting service volume and utilization. So second, evidence that these changes improve patient outcomes is much weaker and much less consistent. Third, there's no clear winner. Fee-for-service, salary capitation, bundled payments, blended models all create different incentives and different risks. And finally, payment incentives alone rarely produce large system savings. Taken together, the evidence suggests that payment matters, but its most consistent effects are on utilization, not necessarily health outcomes or overall system performance. That conclusion is consistent with my 2020 systematic review and research that's followed, like Sandeep's. The most interesting question to me, therefore, becomes what kinds of effects do we observe in practice when payment incentives change? So let's, or change or when we compare them to each other. So let's illustrate that with a few examples from my own work. Before I moved to Canada, I studied organizational level payments for substance use treatment and mental health treatment. When I moved to Canada, I started working on looking at different payment models in Alberta for chronic disease management. So we looked at the academic ARP, now called the AMHSP. When it was introduced in the early 2000s, one of the main goals was to improve quality of care. We did a population-based study of Alberta patients with chronic kidney disease and diabetes. We observed patients seeing salaried physicians were sicker. So like Sandeep talked about, like there was a difference in the patients seeing salaried and fee-for-service physicians. So I did matching similar to what Sandeep explained, and I did actually match on both patient and physician characteristics that I had. And when we compared these patients, when they were more similar, we actually found no significant evidence of a difference between equality indicators or costs or visits. And in fact, salaried physicians actually had a higher visit rate after matching, but it wasn't statistically significant. But one thing that I noticed when I was doing this, that the variation between the physicians was actually had a bigger effect on outcomes than the payment models themselves. So that got me really interested in physician variation and understanding how that's at play here and influencing these payment outcomes that we're finding. So from this work, the lesson is not changing payment, is that changing payment alone may be a relatively weak lever for broad goals like improving quality. So after I did this, I got also interested in cardiology. And in our cardiac imaging work, because I was so interested in variation, I decided not to continue matching patients and instead focus on measuring the variation between the patients and trying to understand if that variation was driven by difference between patients or differences between physicians that they were seeing, or even differences in the sites where physicians were practicing. So my favorite project that we did find that payment model was strongly associated with testing. So compared to salaried specialists, imaging rates were about 2 times higher among fee-for-service physicians and nearly 3 times higher among fee-for-service physicians who were also able to bill for interpreting the imaging tests. So we did still find, even after adjusting for everything we could, there was still substantial physician and site level variation after these adjustments. So payment matters, but it doesn't explain everything. So now I'm working in women's health. So I contributed to, I haven't looked at some compares, most obstetrics and gynecologists are paid fee for service. So I haven't been comparing payment models, but I have been looking a lot at behavior and happy to share those at future webinars. But I did work on a systematic review about perinatal payment models. And that work, among other things, found that bundled payments compared to fee for service were associated with fewer cesarean deliveries and lower costs. But when we looked at a different type of kind of episode or case-based approach to payment, that was actually associated with an increase in cesarean deliveries compared to fee for service. So the lesson here isn't that bundled payments or case-based payments are good or bad, but that the design details really matter. So putting all this together, I think these examples suggest that payment can influence behavior, but its effects depend heavily on specialty type, context, implementation, how we're measuring this, and the outcome we're trying to improve. So that leads me to another interesting example where we looked at how payment incentives interacted with the way services are organized. Okay, so this figure looks at growth in cardiac diagnostic testing over time in Alberta from 1995 to 2020. And what's striking here is the substantial increase in testing that occurred following the expansion of private testing outside the hospital in the late 90s. So this growth did not occur by chance, and it also wasn't accompanied by a corresponding increase in treatment. So in the mid-90s, the Alberta government wanted to improve access to cardiac testing. So, there was a clear policy objective, and what the first strategy they implemented was allowing testing to occur in private community-based facilities. So that decision changed the organizational structure of care, moving the majority of testing outside of public facilities. So at the same time, physicians working in those settings were paid fee for service. And then what also was introduced at this point was that cardiologists could get accredited to bill for both seeing patients and for interpreting the imaging studies. So the result was a system in which increasing testing activity could be financially rewarded, while much of the accountability for testing remained weak. I think it would be a mistake to conclude that fee-for-service alone explains what's going on in cardiology in my studies or in Sandeep's studies. I think fee-for-service exists in these settings. Fee-for-service can exist without this being the result. So what appears to matter more is how the incentives are interacting with organizational structures. So in this case, payment incentives were layered onto a system that expanded community testing capacity, supported physician interpretation, and provided relatively few mechanisms to manage this. So for me, the broader lesson is payment reforms do not operate in isolation. They interact with governance structures, accountability mechanisms, data systems, professional autonomy, and how services are organized. And that's why I think it's difficult to talk about payment reform without talking about these other aspects of the healthcare system. So what gets rewarded matters, but so does the structure that those rewards operate in. So when we're thinking about this concept of payment reform on its own not being enough, I also like to think about these 4 issues. So incentives, including payment, but there's other kinds of incentives like non-financial incentives that are out there that can reward certain behaviors. Another thing to think about is workforce. So who is even available to provide this care? Do we have the right mix of providers? Are specialists spending their time on activities that truly require specialist expertise? The third is governance. Who is accountable for quality, access, coordination, and system performance? Is anybody accountable for that? And what tools exist to support this? Or what tools could we create to support this? And the fourth is variation. Why do patients with similar needs sometimes receive different care? Like, why are sicker patients seeing the salaried physicians in the first place? So understanding where variation exists can help identify opportunities for improvement and tell us where interventions are most likely to have an impact. So these four factors are clearly interconnected. Payment influences, and payment is a type of incentive, but workforce constraints, governance structures, and variation in care also shape what happens in the system. So I'd be cautious about viewing payment reform as the solution to broader system challenges. Improving care requires a combination of incentives, workforce planning, accountability, performance measurement, and feedback. So payment matters, but it operates within a much larger system. So where does that leave us? Instead of asking, should physicians be paid fee for service or salary or through a blended model, I think our first question should be, what problem are we actually trying to solve? If the objective is to reduce low value imaging, payment will need to be combined with tools with more teeth than just choosing wisely guidelines. So my overall takeaway is payment models matter, but their most consistent effects are on utilization, not necessarily on health outcomes or spending. Payment reform is most likely to help when it's tied to a clearly defined objective, supported by credible data and accountability structures, adapted to specific specialty, and combined with non-financial tools. So rather than asking what payment model should we use, we may make more progress by asking, what problem are we trying to solve? Where does that problem arise, and which combination of policy tools is most likely to address it? And thank you.
Well, thank you so much, Amity, and I think it provides great kind of food for thought. I encourage people, if they have any questions to pose to the two presenters or our panelists as we move forward. Just to comment, it was interesting when you talked about the linkage between being paid for cardiac testing. And I remember for a long time it was kind of seen, and Glenn may be able to comment, as under colleges to be unethical for someone to be owning a testing facility and also be the prescriber, you know, because you end up getting an incentive financially to order certain types of kind of care or follow-up care. And I remember when I was working in industry, the biggest market for pharmaceuticals was Japan for a long time, because the physician who prescribed was also in many cases the dispenser of the medication. And so it just be the volumes were unbelievably high. So clearly that's a clear incentive as one moves forward. But might just pass to the panel now of questions they might have for each other. And I might start with Glenn and then go to Jason. But Glenn, from the just a quick question, any other comments you wanted to have is, what are the reasons that, from a clinical point of view, that you might that might come from cardiologists as to why they do more cardiac testing, perhaps? That isn't based on the fee-for-service model. What are the kind of the counter arguments that might come up? These are the reasons why we might order more cardiac tests.
Well, I think, as Amity pointed out, this all has to be taken into context of the setting, which is in our case of our studies in Alberta, and I think a lot of Amity's studies been in Alberta as well. We certainly had a great foundation of data from Amity's work that she had done that really got us interested in this. So just the comment about the testing, which is available in Canada on a private basis, and Amity already showed the graph showing a striking increase, which, by the way, wasn't shown, is not accounted for by population growth in Alberta. The other slide that would go along with that, which I have data from IHE, indicating that the billings of fee-for-service cardiologists has gone up 350%, so 21.9% per year since around 2007 or 2008. That's not entirely explained by, of course, fee-for-service, but it is partly explained by both the fee-for-service model and the available testing. So I think the setting part is important. So neither the physician nor the patient has to have accountability in terms of what it costs the payer, the government. So in a fee-for-service system, all of the risk is in the government payers. They have 100% of the risk for fee-for-service in terms of the volume of testing that's ordered. So that is one argument in favor of payment reform modification. But as Amity said, that's not the only solution. I hope that partly answers your question, but I think the context is Alberta environment is quite unique in terms of the availability of cardiac testing. Patients demand it. That's another part of it, and it's widely available.
Okay. And Jason, I don't know if you had any kind of observations or comments from the presentations that have been presented, and certainly you studied a lot of funding models, like institutional funding models, as well as their linkage to provider payment. And I think often they're separate. So I know you might make some comments around the bit of the bipolar, no, I wouldn't say bipolar, but the nature of kind of providers, physicians in particular, being paid separately and not linked to other particular funding models. But any observations or comments from the two presentations?
Yeah, first, I'd like to say that both presenters did a very balanced perspective of what they found, and I think that was really helpful in the way that it was presented. So nice work to both Sandeep and Amity. I suppose I would come into the tail end of Amity's presentation, and as policymakers weigh the pros and the cons associated with the different options before them, what types of information and data flow to either providers, provider organizations, or the Ministry of Health's organizations, so at the different micro, meso, and macro levels of information should flow to be able to know that the cardiac service delivery models are providing what the government needs for its population. Does it need patient-reported outcomes? Does it need experience with healthcare measures? Who should be operationalized to collect that data, and how should it be interpreted, and how should that flow back into, incentive structures for not just cardiologists, but the different players in this game, which would include institutions, inpatient rehabilitation facilities, long-term care, and for ministry payers.
Right, yeah. And it is interesting, as Amity's comment, in terms of who do specialists report to, or who are they accountable to? And Glenn, you might have comments, because often it isn't a formal relationship. There is a set of fee codes which I can charge. I'm accountable for the care of my patients, but and a bit of peer kind of reporting that happens sometimes. But do you have any comments in terms of not just the nature of the funding model, but how it's linked to some kind of accountability arrangement for making sure one's available to do that service? What happens if bad outcomes occur? If there is overutilization, what are the measures that can be taken? Because cardiologists don't work for someone; they are independent. So, any comments you have in regard to the accountability relationship in linked to funding models of specialist physicians?
I mean, there is some accountability, but it's largely, I would say, peer to peer, as opposed to from between the payer and the provider per se. So the Alberta Health, in the case of Alberta, or any provincial Ministry of Health, doesn't behave much like an insurance company, so to speak. So they don't have the robust accountability measures to ensure that each and every cardiac test that I think Jason was alluding to, some outcomes that we can look at, we don't have that data, at least at the moment. We could do population analytics to predict the output based on the population characteristics, but that I don't think is done. So I think it's more of the entire agency of how many tests are ordered is collectively in the hands of cardiologists and to some extent patients who are wanting to be tested, so to speak. But it's largely the responsibility of the physician. So very little accountability overall, only at the extreme end. So if there's extremes in the billings, I think the ministry will pick that up. But I think Amity alluded very importantly to the structure that's in place, and that structure is pretty loose, I would say, in terms of financial accountability between payer and provider.
Yeah. And Amity, you looked at, I know, at cardiac testing as well as Sandeep, but I'll go first to Amity. There was a question from Alan about, do we know the level of cardiac testing in Alberta compared to other provinces or the OECD countries? Are we, how much of an outlier are we, or is increased cardiac a trend everywhere?
That's a great question. I don't know the answer to that. I think, I mean, what Glenn's saying based from the IHE data results Glenn shared, it sounds like it's maybe a national increase, but I think Alberta and Ontario, I'm pretty sure, are the only provinces that allow private testing in this way. So just based on economic theory, I would guess that Alberta and Ontario have the most. But I think Alan, that's a really great question, and we could study that.
Yeah. Sandeep, I don't know, or Glenn, on your recent study work, whether or not that issue came up in the literature search that you had done.
Yeah, we just observed in the systematic review, which Amity I think would be very familiar with as well, is that the physician the highest billing quartiles or quintiles in Ontario did more testing. So we didn't prove the same association that we had in our study, but it's more, there was a strata within the quintiles of billing amounts and an association with a higher degree of testing. So there was a gradient.
Yeah, and also another. Oh, sorry. Go ahead, Glenn.
I say one other thing, just so that the 350% growth is Alberta. That's from 2008 to 2023, I think it is. We have from IHE, and that's striking, and it's strikingly higher than any other province. That's just gross billing. That doesn't talk about cardiac testing. It's just fee for service billing that IHE provides as a national metric. So
yeah, and it is complex because sometimes there's technology advance in certain kind of testing, which provides new opportunities for or expanded scope. Bree had a comment of and all of you can comment, and I think Jason, you've looked at this in other places too about trying to get, how do we get buy-in for payment reform as government or physicians or health service delivery organization when it often feels that most of the leverage or power is held by physicians. And I do think there is certainly resistance to certain particular kind of reforms, and with short-term government reforms, there's a waiting out that one can have to keep. So one about getting buy-in, and also Glenn, you might comment. I think it's the physicians are not monolithic. I think there's certainly people, quite different groups and attitudes towards keeping the system kind of as it is in control as independent contractors, and others who are much more shifting open, who are younger, to different types of arrangements. But getting buy-in for payment reform from providers, and Jason, perhaps how long it takes from your observation in some other countries about moving payment reforms forward.
Yeah, thanks, John. I have done quite a bit of work in my past among Nordic countries associated with hospital payment reforms. And, you know, in every instance that I've worked in, including Ontario, substantive changes and meaningful policy change for funding differently has been led by government. And I think it's been really challenging to see in a number of provinces, for instance, including my own, where the the structure and the process for paying for healthcare has not changed in decades. And I think that's largely true in Alberta, Saskatchewan, and Manitoba as well, too. So that things really haven't changed at all. And that is, in stark contrast with physician organizations in many of these provinces advocating for reform, for instance, in hospital payment models, whereby they would like to move away from global payments into a DRG-based payment model. So it's really hard for me to pick one or two instances associated with what are the key levers other than pressures on governments to try to achieve something different than what is occurring now. My personal opinion is that the healthcare system in Canada's province really is bedeviled by access problems and access and access and access. And if we want to, prioritize resolution of the access problems and do it safely for patients, but also protect financial risk to payers, we should be paying for access, and we should not be trying to do everything under the sun with very complex models or even very simple models, but we should pick our priorities. And we don't see governments picking what the priorities are, so it's really hard to align the policies and the financial incentives to achieve, this broad basket of goods.
Yeah, just a comment, Jason, because you worked in the United States as well. And I know Kaiser Permanente is often highlighted as a group where there is a clinical physicians organization, which is given a large kind of pot of money, but seems to have some accountability collectively as a physician group for achieving outcomes. And I think there are some examples, I think, in Germany or other places where there's a bit more outcome accountability put on the physicians as a collective group. I don't know if that's an appropriate observation where they're not outside of the performance accountability metrics of the health system.
Yes, great question, John, around some of the successes of some of these integrated delivery systems in the United States. And Kaiser's the most popular one, but there are others as well, too. And I think the biggest difference is that these systems generally operate on a capitated payment model, or blend and pool their fee-for-service related incomes together. So that, it seems really a tough row to hoe to think about Canadian physicians moving to capitated payment models where they're jointly accountable for financial risk and clinical outcomes together, like the Kaiser physicians, which also own the insurance program.
Yeah.
So we are a million miles away from looking like a Kaiser Permanente integrated delivery system.
Yeah. No, I get it. There's a question from Judy Bertzel. Wondering about the panelists' thoughts on the role of Alberta citizens with respect to accountability with getting value for investment. I'm not sure how one would identify that. And just the role of kind of a patient's accountable system. I think that's very, very hard. I mean, you could have certainly there's some reforms now associated with testings in Alberta with self-referral, which has significant concerns from the clinical community. It does put some choice in mechanism into the hands of consumers. So I think there would be big questions around some externalities or some bad things that might be able to happen in terms of inappropriate resource use there. But I don't know if there's any comment, people, around the role of citizens or patients themselves directly involved in some kind of accountability of provider payment.
Well, my opinion, yeah, I want to comment. Patients absolutely should be involved, and citizens as well, because when we're talking about the large-scale payer for 71% of healthcare expenditure in Canada, including Alberta, it's the taxpayer. It's the general taxation and the taxpayer. So there's patients who are also taxpayers. So in theory, there should be a lot of buy-in from the public about how we organize things, as Amity says, and ensure that we're getting the best value for our healthcare dollar from the physician services budget as it stands right now. And I would argue that although there's not one solution here, we have to do better. As Jason pointed out, we have to do better than we're doing right now, because we're not optimizing access, and we're not having a fiscally sustainable physician services budget. And then the other thing that Sandeep alluded to, which is very important to recognize, and the panel knows all this, but it's under-recognized, is that physicians control up to 70 to 75% of all healthcare expenditure. They only represent, payment for physicians is 12 to 15% or so, but the control of the expenditure is in physicians' hands. So, and we believe that the payment models may determine, at least for utilization, how that money is spent.
Yeah. Jason, you, I think, had a comment?
Yes. Sorry, I was just going to build off, and I entirely concur with Glenn's perspective in that I do believe citizens have an outsized role in trying to shape healthcare funding policy and funding reforms. I mean, certainly in the settings that I've worked at, MLAs are very responsive to public's pressure on them and pointed questions associated with that. And then MLAs have a role in shaping their government's response. So my position is citizens play a key role, and that they should consider being single issue voters as they look forward to the next election, and really carefully scrutinize and hold accountable the parties for putting forward comprehensive health policy platforms, and then vote accordingly.
Yeah, I do think it's interesting around the value for investment. I think point is we do go up and down in terms of how we report on the performance of our system, in terms of what are we achieving for the amount of resources that we provide, what is the variation that occurs perhaps across regions of the province or even across providers. And Glenn, there's significant resistance, I think, often for reporting, you know, even at a macro level. I mean, some places really report down much more aggressively, but I think in order for us to assess the impact of funding models and the value of investments, any comment you might have on the performance reporting as an incentive and how that could be significant. And Jason, you might have comments, or Amity, because I do think often we look at incentives as purely financial, but they can be very much public display of performance information that it's a way of holding people accountable to what they're achieving.
Well, I mean, one of the strengths in Alberta is we've been using it to show our findings in this study, is we have an enormous resource of data in a province of 5.2 million. So we could use that data more effectively to create health system value by being more trying to predict the output of the system, which includes the design and the structure and processes of payment models. So I think we could use our data that we have already to do like what Kaiser does, or what Geisinger or other systems like, you know, White Mountain Health does, where they use their predictive analytics to predict the output of their system and integrate things like the payment models, creating accountability within that, so that we know what to expect. And so when we can then say, did we do too much cardiac testing for the same outcomes or not? And we don't really look at that data right now. I think that would be the major step forward for us.
Yeah, and I do think we did have some structures with the strategic clinical networks, Glenn, that tried to start to develop and look at unexplained variation. I think there's still embedded some of the programs in cardiology and cancer in some programs, but I think that's important. But Jason, I don't know if you had any examples of other jurisdictions or some thoughts around pretty aggressive performance reporting around and how that can be a useful tool.
No, and I think, I mean, mine are very minor in that they are associated with financial performance, but I might, hand it over to Amity, who might be able to draw on some of her experiences in Alberta and the United States.
Yeah.
Sure. Yeah, I am American, so I did all my training there. I'll come out. But I this has come up before of like who kind of could be the boss of the specialists, I think. But like, so in the US, in addition to these like integrated delivery and insurance systems, like insurance companies, I think, are the ones that have much more power. And there's like established, accreditation standards for health plans for what kind of measures need to be met. And that so when they contract with physicians and physician groups, there's just already these structures and understanding that like they have to be accountable for certain things, and that can cause its own problems, right? When you're paid from all these different payers, then you have a challenge of like, whose incentive do you actually care to respond to? But there's just these like established structures. So when I moved to Canada and learned about physician payment, I was very confused that it was just operating outside of any kind of measurement. So I know there's been like, there's different levels you can do this at as well. I think, John, you also alluded to like some audit and feedback strategies, which have definitely have been used, some in Alberta, and those are effective, but we haven't had like a systematic approach to that, right? It's been like examples here and there. So I think we could think about like, could some of this accountability come from within physicians or within more friendly physician environments, maybe, if that's a way to put it, or does it come more top down, like could the government act more like an insurance company, for example?
No, I think that's important. Sandeep, did you have a comment?
Yeah, actually, a few months ago, me and Dr. Glenn, we're talking about how we can make, patients involved in this accountability. So we were talking about like for every visits, like there should be a rating system. After follow-up visits, a new consultation, patients should receive a survey or some kind of, rating parameters that we receive, that we observe on Uber Eats, on DoorDash. After delivery, we rate the driver, we rate the restaurant. So maybe that kind of system can be involved, and we can link that kind of data with the administrative data to see how the patients are feeling, because there are always two ways. The one way is patients always feel cared when they receive testing, but there is another way, like there's a societal perspective that patients have to take off from their workforce, then they also have to, travel, there are fuel costs, there are parking costs. So there are two ways, I guess, and if we make some kind of those accountability system or those kind of initiatives, we may determine better which approach we should, move toward.
Yeah, no, I think it's good. And I do think we want funding models to reward and improve performance of the system. And I think the key thing is to define what good looks like. And then, first, and be able to report that kind of in a relatively thoughtful way, but be able to provide much more transparency. And I do think Alberta seems to have the existing elements of integrated data, integrated lab data system, where you could really measure kind of utilization and performance. And I know their work the Obrien Institute's doing, I think I'm really looking at the learning health system, where we learn and are accountable for ourselves. And certainly that funding model should be really linked to outcome and performance. And as you said, Amity, what do you want what improvements do you want to make, and make sure to match the funding tools to be able to move forward to that. Well, thanks very much, everyone, for participating today. I'm going to have to close off. I will be sending the material around to everybody. And if anybody does have particular suggestions of further topics, please get a hold of us, because we're going to try and really explore through a series of these educational things. And please, everybody, there's a QR code to get to the event site where some of the articles mentioned today were posted, and we'll be putting up the PowerPoints there. If the speakers could send their latest ones, because I know they were doing adjustments the last couple of days as we went forward. But thank you, if everybody can join me collectively in thanking our panelists and speakers, and please enjoy the rest of your day, and thank you for joining us.